خدي لي الكهرباء. سهرة.
Okay, we're ready now. I will start in Spanish and then Natalia and then Dr. Salim.
Right.
Well, buenos días a todos. Continuando con el programa de este Congreso Internacional, a nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, presidente del Congreso, The World of Neurosurgery in Your Fingertips, a quien agradecemos por la organización de este magno evento, así como a la doctora Deyanira Capi, presidenta del capítulo ASPNet, al doctor Salim Abdurraouf, presidente de Walter Edandi Neurological Society, al doctor Babak Kateb, presidente de la Society for Brain Mapping and Therapeutics, the Brain Mapping Foundation, todos ellos vicepresidentes del comité organizador, y al doctor Parménides Guadarrama Ortiz, director del Centro Especializado en Neurocirugía y Neurociencias México. Es un honor para mí presentar al doctor Ahmed Alkhani. Él es el Head of Neurosurgery Scientific Council at the Saudi Commission for Health Specialties. Les recordamos que esta ponencia será transmitida a través de la página de Facebook de la ASPNet, también en YouTube en nuestro canal y en el canal de Neurosurgical TV. So, Natalia, I give you the floor, please.
Yeah, thank you, Ahmed. Thank you. My name is Natalia, and I'm representing the organizing committee of the World Congress of Neuroscience, the World of Neurosurgery at your fingertips. We are welcoming all of you. Thank you for continuing watching us. I would like to say many thanks for the cooperation to the ambassador of UNESCO, for the chairman of the Congress, Mr. Jorge Herrera, for the organization, for the idea of this Congress. Thank you a lot. Also, we would like to say thank you to our partners, Walter Edandi Neurosurgical Society and Foundation for Brain Mapping, to Dr. Babak Kateb, and thank you to the WAPS Medical Students Chapter, Mexico, for the broadcasting, and to the Neurosurgical TV. And also many thanks to the Dr. Salim, a great moderator, Neurosurgeon-in-Chief of the Abdulrauf Institute of Neurosurgery, founding chairman of the Department of Neurosurgery at South Louis University, and global president of the Dandy Society. So now Dr. Salim will introduce our next speaker.
Thank you, Natalia. Thank you, Ahmed, and to your team in Mexico City, an amazing group of students in Mexico City who are coordinating all this effort. I'd like to recognize the visionary leader, Jorge Herrera, to putting this great Congress together and for all his work for years to put this together. So I really commend him for that. We have a special speaker today that I'd like to introduce, Dr. Ahmed Alkhani. He is he did his training in neurosurgery in Canada. He's back in his home country of the Kingdom of Saudi Arabia, where he currently is the head of neurosurgery at the King Abdulaziz Medical City. Dear Dr. Ahmed, it is great to have you with us. He's gonna present to us about trigeminal neuralgia, microvascular decompression. Great to have you with us, Dr. Alkhani.
Thank you very much. Thank you very much, Prof. Salim Abdurraouf. Thank you very much to your team, outstanding organization. It's my honor to be with you here today. Shall we start?
Please.
Okay, so. So once again, it's my pleasure to be with you here. Just to mention that I'm representing few institute, King Abdulaziz Medical Center, which is one of the tertiary hospitals in our country. I'm also presenting the Saudi Commission for Medical Specialties in Saudi Arabia, the Saudi Association of Neurosurgery. and I'm the head of the educational committee of the Pan-Arab Neurosurgical Society. So it's my honor to be with you today. I'm going to talk today about trigeminal neuralgia. Always when we talk about pain, it's very important to re-understand pain in terms of physiology, neurophysiology, but also very important to understand pain in terms of human reaction to pain. And I always like to put these two slides into action because the patient will come to you to the clinic complaining of pain. However, he's the only one who can tell you that his pain is better or worse, severe or not severe. And it's all a reaction sometime of his emotional feeling of this pain and how he reacts to the treatment methodology. So I always like to put this slide whenever I talk about pain, I talk about management of pain. We do have a lot of objective way to score pain. Nevertheless, people who deal with pain syndromes always recognize that improvement and deterioration sometimes is subjective to a lot of emotional background. Nevertheless, when we come to trigeminal neuralgia, this may be one of the very few exceptions because the pain of trigeminal neuralgia is by far one of the worst pain a man can experience. And it's by far very severe, intense pain that almost all the patients will come with a similar scenario, classical scenario of the pain shooting, come on and off with the allodynia, hyperalgia, feeling the pain in one of the subdivision of the trigeminal nerve, the V1, the V2, the V3, or any combination between these two segments of the trigeminal nerve, or all of them. So maybe trigeminal neuralgia can be put as one of the very few exceptions to pain syndrome, and the management is somehow very dramatic, that the patient will be very happy with the results immediately and can tell you exactly that he benefited or not from your surgical intervention. We call it trigeminal neuralgia, but it has many names in the literature, like Fothergill's disease, Tec de la Rue in French. It's a suicide disease because the amount of pain that can be experienced by the patient sometimes can be so severe that the patient can do anything to stop this pain. Definitely one of the worst a man can experience and can lead him to a lot of psychological status that can contribute to his quality of life. The incidence of trigeminal neuralgia is about 400,000 per year in a city of, our city in Riyadh of 5 million population. You are talking about 200 cases per year. Nevertheless, in warm countries, this incidence is much less than other countries. In cold countries, much higher. Even within the same country, like in our country, when you go to the mountains where the weather is less in terms of temperature, the incidence is much higher than going to a desert area where you have a warm atmosphere, and the severity, the frequency of the attack of trigeminal neuralgia is much less than in the mountain. It's usually unilateral, right to left is almost the same, maybe slightly more common on the right side. Trigeminal neuralgia do exist, and I have seen like maybe a handful of cases of bilateral trigeminal neuralgia with the classical pictures. Rarely comes at the same time as an acute attacks bilaterally, but sometimes it goes from right to left and left to right in the attacks that can come with time. The peak age is in the 60s to 70s, and this makes the management of trigeminal neuralgia as a bit picky in identifying the right candidate to the right treatment option, medical intervention or surgical intervention. And again, regarding the divisions of the trigeminal nerve, it can attack V1, V2, or V3. However, we know that a combination of V2 and V3 maybe is the most common combination for trigeminal neuralgia, followed by the three branches together. Again, in our country, when we move from winter to summer with the use of air condition, the incidence of acute attacks rise up, and we start to see more patients in the clinic. And as I said, in the winter, when the weather is cold, especially at the mountains, the attack is usually more severe and more frequent. Again, the incidence, like in a cold country like UK, for example, we are talking about almost 30 cases per 100,000 or 300 per million, as compared to the international incidence, which is about 40 per million population. And this can give you an impression about the effect of weather into trigeminal neuralgia. And sometimes that makes us confused to understand how can etiology of trigeminal neuralgia get affected by the weather outside. Nevertheless, this is a very obvious observation, and many people who work in the field of pain, especially in trigeminal neuralgia, do experience this phenomena, and they realize immediately that the colder the weather you go, the higher incidence of trigeminal neuralgia, regardless of the pathology or the etiology of it, the pathophysiology of it. Let me show you here a patient, local patient, describing a patient of trigeminal neuralgia. I understand that this is in a foreign language, but she's giving you a classical presentation of trigeminal neuralgia in the left side of her face, affecting V1, V2. She is describing that this is the worst experience she had when pains come. It's intolerable. It's really affecting her badly. And when we ask her how much you experience the pain, she will immediately say 10 out of 10, no question asked. The worst ever it can be. And he asked her, when you take medication, how much improvement or management? She said, well, it can reduce slightly with the medication, but as soon as the medication effect goes away, the pain is back in the worst, and she's describing the V1 and goes down to the ear, and as if she's describing the anatomy of the trigeminal nerve, V1, V2, and always point out to the midline that the pain does not cross to the other line, as if there is a line that can demarcate where is the pain is. In terms of investigation to know exactly what's the pathophysiology of trigeminal neuralgia or the etiology of specific patient with trigeminal neuralgia, many physicians, primary care or neurology, would go by the history as the solo items to diagnose trigeminal neuralgia. When you have the classical presentation, they label the patient, they diagnose the patient provisionally as trigeminal neuralgia. And it comes now, do we need to do neuroimages? But, and this is controversial, however, in a review article with the practice parameters for the diagnosis, that routine neuroimaging may identify a cause in up to 15% only of patients with trigeminal neuralgia. This includes the vascular changes that can be identified by the MRI to identify possible neurovascular compression seen on the MRI that can be translated into the symptomatology of trigeminal neuralgia. And again, only 15% of patients you can identify that in a pre-management MRI, even with gadolinium. And there is no evidence to support that the MRI to accurately identify the patient for microvascular decompression procedure, because identifying abnormality does not mean that this is the causative vessel that's causing the trigeminal neuralgia, although it looks classical on the images. That doesn't mean removing the etiology seen on the MRI will lead to better results from the surgical intervention. Nevertheless, the surgeon feels more attempting to go for surgery as he can see the pathology on the radiology, and hoping if we separate this artery from this nerve, the patient may have a better outcome. When we look at MRI in general, it's very nice to identify that trigeminal nerve, identify the territory of the trigeminal nerve, see if there is a vascular compression that can come from the superior cerebellar artery that usually can come from above and lead to trigeminal neuralgia, mainly starting with the V1 as coming from above, or from the ICA, which is coming from below, and usually start with the lower part, the V2 and V3, but this again, not classical. But the main reason why we do an MRI is not only to identify this possible vascular relationship with the nerve, but rather to rule out other significant pathology that can change the surgical plan or the management plan, and a huge dolichoectatic vertebrobasilar structure can, number one, identify the vascular etiology into the trigeminal neuralgia, and can warn the surgeon that when he's going to go for surgery, he has to deal with this vascular structure and be ready to deal with this vascular fracture before going into surgical intervention and microvascular decompression. Of course, one thing you need to able to identify is the possibility of demyelination process, like this young woman who came with left side trigeminal neuralgia, and the patient has clearly identified an area of demyelination that you can see here on this slide at the area of the origin of the trigeminal nerve from the brainstem. And this patient will make microvascular decompression maybe not the best option, and the outcome from even other modality of treatment may not be as good when you quote outcome for the patient if the patient has demyelination process with MS patients. It's not contraindication for other modalities. You can always try it, but at least the patient should be aware that the outcome may not be as good as identified with other patient who does not have demyelination process in multiple sclerosis. You need to make sure that there is no CP angle tumor, and we have seen a lot of trigeminal schwannoma, a lot of vestibular schwannoma extend up and cause sometimes severe trigeminal neuralgia, and the surgeon who needs to go for microvascular decompression should be prepared for that with a plan to go for total resection of the vestibular schwannoma or trigeminal schwannoma, and not only as a microvascular decompression. One rare but definite etiology is epidermoid cyst, and I've seen at least handful cases of epidermoid cyst causing in the CP angle, causing trigeminal neuralgia, and I can tell that this patient has a very, very, very severe symptomatology, one of the worst I have seen, and they do very well if you remove the tumor completely if possible. However, we know that epidermoid, sometimes you try to remove the tumor completely, wash out the content of the epidermoid cyst. Nevertheless, sometimes patient can come back with the pain. So this rare etiology for trigeminal neuralgia should be dealt with in a different way and through a different scope to treat the primary pathology and not only the pain syndrome of trigeminal neuralgia. When we talk about management, we have to put in line what kind of medications we use for trigeminal neuralgia, and many patients will volunteer that they went through non-steroidal anti-inflammatory as the first line. They pick up non-steroidal like Advil or Voltaren or whatever medications available, which is usually from over the shelf, or paracetamol, and it does help with some patients, but carbamazepine or Tegretol remain the number one anti-trigeminal neuralgia medications that we all use, and we start with at least for patients with trigeminal neuralgia, but not all patients are satisfied with increasing dose of carbamazepine. We started with 200 milligram twice daily and built it up slowly. Sometimes we reach more than a gram of carbamazepine per day, or sometimes 2 grams, with limited benefit from management point of view and putting the patient back in their life steam and back to work and back to action, especially when there is an acute severe attacks. Gabapentin, pregabalin also been advocated. I do use carbamazepine, I do use pregabalin. Baclofen been advocated with many neurologists with some good benefit in some patients, only partial. Phenytoin, Lamictal, all are options. But when we go to evidence, class of evidence, it's only carbamazepine that has a level 1 or level A evidence that it is effective in trigeminal neuralgia. Oxcarbazepine comes as a level B, and the rest, like baclofen and Lamictal, all goes in level C evidence that they can manage. And topical ophthalmic anesthesia, we all know that it does not help that much in the term of management of trigeminal neuralgia. What options we have to offer to patients who fail initial medical treatment? And once again, we don't go for intervention unless we are clear that the patient failed medical treatment, or we have an MRI that showed other than simple vascular relationship to the trigeminal nerve, like tumors, as we said, meningioma, schwannomas, or an epidermoid cyst. We do percutaneous radiofrequency lesioning, and I prefer this modality of intervention percutaneously, but other options like balloon micro compression is also a valid option, a very valid option, and practiced by many neurosurgeons or pain specialists around the world with good results. Glycerol injections comes more into history now because of some short effect of the glycerol injection and some complication that we do see in many patients. Stereotactic radiosurgery gained a lot of ground recently, at least in the last like 10-15 years, as an option, a valid option, by giving small dose of radiation stereotactically to the trigeminal nerve, and that can lead to reasonable outcome, and I will come to that in a table at the as we go with our presentation. Some people use neurectomy, peripheral neurectomy for patients with trigeminal neuralgia, like V1 or V2. It may help sometime, but from my experience, it's short-lived, and it's a dramatic pathway that you have to cut or avulse that a branch of V2, peripheral branch of V2 and V1, supraorbital or supratrochlear nerve. So I don't use this anymore. Then we come to the interest topic for today, which is the microvascular decompression as an option, a valid option, and we'll come to that in a few minutes. So how we do percutaneous radiofrequency? We all learn how to do percutaneous canalization of the foramen ovale. Everybody has his own way, doing a simple X-ray by fluoroscopy, taking the patient to the radiology suites where he can have a better images and more accurate planning for your needle insertion, or do it CT guided. We start to do it a lot in the 4 or 5 years. Patient under the CT scan and CT guided insertion of the needle and canalization of the foramen ovale. And we all know that we start with the V3 and go up with V2 and V1. We can stimulate and then initiate lesion. Everybody has his own protocol but I usually stimulate first. And once I am happy that I am at the target of V3, V2, or V1, or in all of them, I start lesioning, and I usually use 60 degrees centigrade for 30 seconds as the initial lesioning, and then re-evaluate the patient and make sure that corneal reflex still intact, and the amount of hyposthesia experienced by far almost all the patients after radiofrequency lesioning has started, then that will give me an assurance that this can be a long-lasting benefit effect from the intervention. When we come to the balloon, as we pass through the foramen ovale, they inflate the balloon and pull it up to initiate a traumatic effect on the trigeminal nerve, and that will lead to a similar benefit from the radiofrequency lesioning. But I do prefer the radiofrequency, as you can selectively identify the branch that you want to treat and give the just right radiofrequency lesion that you want, that you can have the good results from and avoid complication from. We talked about radio surgery as an option, and again, in a center with a good radiosurgery, regardless of the machine used, sometimes we can have reasonable results. Now we come to microvascular decompression, and in here we have to pay a tribute to Professor Peter Janetta, who started the whole process of microvascular decompression. And in many centers, they still call it Janetta procedure, and they don't call it microvascular, to recognize him as the leader, the pioneer who was able to identify this pathophysiology of the trigeminal neuralgia and the surgical option to treat trigeminal neuralgia, identifying that at somewhere on the course and usually proximal, there is a relationship between the trigeminal nerve and the vessel that can press on the nerve and cause the pathology. And if we were able to separate the nerve from the vessels, you will be able to have a good outcome in the future. And this is some of the landmark anatomy. How do you do the incision? But I will explain our technique in a minute. And again, this is the trigeminal nerve, and you have the ICA below or the superior cerebellar artery above. Either one of them or their branches can be the causative pathophysiology agent for trigeminal neuralgia. In our center, we like to put the patient in supine position with the shoulder supported, and then the patient's head will be parallel to the floor. The patient, I like to use the C-shaped incision, where we can identify our area of the sigmoid sinus, the transverse sinus, and the angle there is the right area of entry. And of course, the use of intraoperative monitoring is highly advocated, highly recommended, just to make sure that the procedure is going very well and there is no interruption to the facial nerve, to the vestibular nerve, to the cochlear nerve, more than to identify the trigeminal nerve and the benefit from our surgical intervention. Again, in vast majority of cases where you have the pathology, you were able to identify the causative artery that can, or branch of it, that can lead to the trigeminal neuralgia. But many people advocating that venous channeling or venous structure can be a cause of it. I'm not sure about that, but many papers and many studies elaborate into the possibility that venous structure can be a causative etiology for the pathophysiology of trigeminal neuralgia, and advocating if we separate the veins from the nerve, that will lead to a better outcome. But we can discuss that later on, and I'm sure many people may agree or disagree with this. I'm more toward disagreeing with this part, but I fully respect the rationale behind calling the venous structure to be the causative etiology. Let me show you a video. It's a long one of a case of trigeminal neuralgia, and I'll illustrate a few things. This, for example, after we open, the first thing we want to make sure that our craniotomy is as high as possible, that you need to identify your transverse sinus. As lateral as possible, you need to identify your sigmoid sinus, and you go in that angle. And if you go in that angle, down all the way, there is nothing but your trigeminal nerve. So there is no point in identifying the 7-8 complex and go up. If you go in that angle from that view, you can just hit down all the way. We describe the phenomena of arachnoiditis that can come and be in association with trigeminal neuralgia, published with Dr. Salma in Neurosurgery about 7-8 years ago. The amount of arachnoiditis we see with trigeminal neuralgia during the procedure of microvascular decompression may give a hint of some of the pathophysiology that we do see, and the necessity to identify the arachnoiditis, to open all the channels around the trigeminal nerves before identifying the vessels, the causative vessels, and do the microvascular decompression. Very important to identify and respect any major venous sinus that can be there. If there's like a small vessels like the one we have here, it's always easy to coagulate and sacrifice, as you are going to see in a second. And again, there is no traction with these cases. The handheld spatula, we don't put self-retaining retractor. And you can see here with us that we go into the cistern slowly. And find our way into the trigeminal nerve. Every surgeon has his own way and protocol in his surgical approach. I'm just showing you an option of dissection. You can see now the trigeminal nerve below under this small vein, which has tons of variation. And if it's a small one, I do sacrifice it and remove it from my way to be able to see the trigeminal nerve and look for the causative vessels that can be the causative etiology of the trigeminal neuralgia. And again, it's a pure microsurgical technique that once mastered with the skull-based surgery for trigeminal neuralgia is not anyway difficult in that sense. And we can easily go down, identify the trigeminal nerve, but it's very important to identify all the cisterns around. You can see here, for example, the tent, the fourth nerve along the edge of the tent that you need to identify to make sure that it's outside your arachnoid cistern. Save it completely and go back to your trigeminal nerve. Here, trying to dissect the arachnoid all around. I like to use this rosin knife to open the thickened arachnoid to be able to reach to the trigeminal nerve pathway from the brainstem all the way to the Michel's cave and be able to see the whole course of the nerve, to see it from superior and inferior. We're just going to put a patty so we make sure that we do not cause any disturbance to the important structure around. And as you see, we don't need to expose the 8 and 9 complex, but we make 100% sure that we do see the full course of the trigeminal nerve from the origin till the Michel's cave. It's a pure microvascular procedure using fine dissection and accurate, precise surgical procedure, paying extreme attention not to injure any vessels on the brainstem that can have an unwanted outcome post-operatively. And again, we take our pathway all the way till we identify the full course of the trigeminal nerve. Using the hook, we go from one side to the other side of the trigeminal nerve, looking for the thickened wall of the cistern, able to dissect it and do the dissection as we go all the way up, using the sharp hook here with full attention to the trochlear nerve, not to compromise it by any means, but to make 100% sure that the trigeminal nerve is free from any arachnoid adhesion, so we'll be able to manipulate the nerve on either side. Let me see if I can move faster on here. No. It's a 10 minutes video. In a second, you will see that we have to identify the full course of the nerve and to identify a small superior cerebellar branch that has a direct relationship with the nerve itself. And again, here, the whole process is to dissect the thickened arachnoid layer till we have an excellent view of the nerve all the way as we go. And we can see that with using the sharp dissection till we feel that we have freed the trigeminal nerve completely from the adhesions around before we look for the vessels that can be the causative agent for the trigeminal neuralgia. And once again, every surgeon has his own way and his own route to follow in his surgical procedure. You can see there's a big venous channel here distal to the nerve that we protect during the procedure before we identify the artery. I'm coming here from caudal pathway, opening the arachnoid and look for the nerve from its course coming out from the brainstem till it reaches to the Michel's curve with a microsurgical technique using the bipolar sometime to make the field always completely dry and with no option of any bleed. As soon as I open this arachnoid, you can see now the full course of the trigeminal nerve, and using a fine dissector, look for the here the blood vessels that can be the causative agent etiology for the trigeminal nerve neuralgia, trigeminal neuralgia. And again, it will be the time to, you can see here that there is a small artery under the axilla of the nerve, and usually this is the excellent location to identify the vascular structure that can lead to the symptoms of the trigeminal nerve. And again, here in our procedure, we look for these small arterioles, I should say, or small artery. And of course, we look for any venous structures if we believe that the venous structure is or can contribute to the pathophysiology of trigeminal neuralgia. Here we are separating it completely and then putting a piece of telfa to separate it from the nerve. That's going to be in a second, where we start to bring the telfa and put it to separate it from the nerve itself, and put that, I usually describe to the patient in our local language, a pillow that can separate the vessel from the nerve. Most important that we avoid completely any traction on the 7-8 complex, because one of the complications of trigeminal neuralgia, microvascular decompression, is worsening of hearing. This is something mainly due to traction. This is why we like to keep the traction only in that angle with a lot of dissection of the arachnoid and avoid completely the this is the telfa that we are trying to put between the nerve and the identified vascular structure. The size should be good enough to stay, but not huge enough to cause a massive effect that can be seen in post-operative MRI or CT scan at that area. And again, I try to put a small pointed piece of telfa that can separate the nerve from the artery that you can see here nicely going through this pathway, pushing it well, separating it completely from the vessels. Some people like to surround the nerve completely 360 to make sure there is no other area of compression. I don't do that, but I like to inspect all other sites before I call it mission accomplished and start to close. I'm going to move from here to describe the options we have and what's the outcome. I want to start with the radiosurgery The initial improvement in the literature range from 80 to 90%, but this decline with time. For 5 years, we are reaching less than 50%. Usually, this procedure has no mortality. It's done by an expert neuroradiologist, and possible injury to the cranial nerve is high, reaching up to 40%. Anesthesia dolorosa is one of the bad complications that can happen from intervention for trigeminal neuralgia. It's less than 0.5%, but no other complication can be seen. When we go to balloon compression, we talk about 80 to 90%, but this also starts to decline to the 60s as we go. But injuring the cranial nerve in terms of decreased sensation on the long term and sometimes loss or decrease of corneal reflex, that's something very important, can lead also up to 40%. But other complications like meningitis, bleed, swelling, you should put it in mind. Percutaneous radiofrequency, the outcome usually excellent initially, but this also declined to 50s in about 5-year time. And usually we don't experience mortality unless a complication of intracranial bleed or meningitis. We have not experienced this before. Injuring the cranial nerve, if you are more conservative in amount of number of lesion or the amount of radiofrequency heat that you produce, you avoid cranial nerve damage, because you examine the patient as we go and make sure that you don't reach to that stage. When you talk about microvascular decompression, that's supposed to be the ultimate treatment with 100% long-term result. This is not 100% true. Microvascular decompression results from 80 to 95%, but there is a decline, and in 5 years' time, sometimes you lose 25% of the patient, as in the literature. We are now working on studying our long-term results from microvascular decompression and compare it to a comprehensive literature review, because everybody goes for microvascular at the state of art or as the ultimate surgical cure for trigeminal neuralgia, but reality, it's better than others in terms of recurrence of symptoms, but still not 100%. Anesthesia dolorosa is not that common, and cranial nerve injury with fine, precise microvascular surgery is not as high as the rest. But of course, still it's a craniotomy with general anesthesia. CSF leak, complication from anesthesia is not rare, describing that the main age for patients with trigeminal neuralgia is in their 70s, in the 7th and 8th decades of life. So you have to put this in mind when you prescribe your patient with microvascular decompression. But when recurrence happens after microvascular decompression, what do you put in your way to diagnose the reason why your patient did not improve or has deterioration after some time? A migrated implant is always a possibility, and this is why we always like to do a CT scan post-op to know where is the initial site for our TELFA, and if in the follow-up we identify a different location, that means somehow the TELFA has migrated. Different pathology, atypical facial pain, when we start to see atypical facial pain as the clinical picture of the pain rather than pure classical trigeminal neuralgia, or anesthesia dolorosa, because many patients that we operate on had a previous trial of balloon compression or radiofrequency lesioning. So you have to put this in mind. Let me give you a case scenario of a patient who had a microvascular decompression at the age of 62. He did very well in the first 6 months, extremely happy with the results, but then he started to have his pain back in a very severe format, way worse than the initial symptoms that the microvascular decompression happened and operated by one of my colleagues. So first of all, we did the CT scan and identified the exact location of our TELFA. So this is not an option. The microvascular, we know that there is a vessel loop, but we have our TELFA as described in the operative report of our colleague, and we know exactly where is the TELFA located, but the patient has extreme severe symptoms on 4 or 5 medications, including morphine that sometimes prescribes an IV. So in that complex, we were not sure, are we dealing with anesthesia dolorosa or atypical facial pain, or dealing with classical trigeminal neuralgia, but somehow failed the procedure. And after long discussion with the patient, going back to the symptomatology, we were convinced that this is classical trigeminal neuralgia. And based on that, we decided to go again and have a look. And you see here with the exposure, you see our trigeminal nerve here. We see the telfa that's been implanted by our colleague and the axilla of the nerve in position. Look right, look left. We could not identify any other loop in the axilla. The telfa was in an excellent location. We were not sure what to do from there, but we insist to look at the full course of the nerve till it reached to the brainstem. And look here what we have found. Going very proximal and dorsal, we found vessels almost within the structure of the trigeminal nerve, embedded completely within. And somehow missed completely by our colleague who did the initial microvascular decompression. And in here, we try to dissect. You see, it's almost within the structure of the trigeminal nerve that we dissected out completely and dissected from the trigeminal nerve, finding our way to initiate a potential space for our telfa to be implanted. And here's our telfa going inside, dorsally, not as expected. We remove that one and put it across and underneath the vascular loop, protecting the trigeminal nerve, having a couple of photos showing here the vessel, the optic nerve, the vessel and trigeminal nerve, and the telfa. The patient post-op did extremely well. Here we can see that in a photo that the telfa separated the vessel loop from the trigeminal nerve, and we did a post-operative CT scan identifying the previous telfa that we put it back and the new location for our telfa, which separated the nerve from the vessel loop. Come to a small hint about what we do in terms of differentiating atypical facial pain versus anesthesia dolorosa. And this is pure history, building a trust with the patient and identifying, is it really anesthesia dolorosa or not? And because the diagnosis is pure clinical and we don't have yet an objective way to diagnose it and to evaluate the patient pre and post-operatively. But in our hospital, we had a couple of cases with severe anesthesia dolorosa that the only way we did is a cortical stimulation described by Professor Pinfield in Montreal, where stimulating the motor cortex can lead to improvement of the pain syndrome for the same topography site of the painful area. In here, it is in the facial topography lateral in the brain cortex, with then suggested multiple mechanism that needs to be studied more and more in the future. This is one of the patients that we did with the navigation, with the neurophysiology monitoring, identifying the motor cortex that representing the facial area, and then implant an epidural cortical stimulation with reasonable results in controlling the pain. I think I have taken enough time with my presentation. I want to conclude here. For trigeminal neuralgia, we always start with medicine. We don't jump to surgery. But on the other side, we do not need to delay the surgery too much when it's a classical indication and the patient did not have sufficient improvement after the medical management, or the patient start to have adverse effect from the medication itself, especially when we go to multiple chemotherapy, more than Tegretol, and start to add 2 medications or 3 medications, then it's better to go for surgical intervention. Many options to utilize, and we always remember that the risk and the benefit of the procedure that should be customized to every patient with trigeminal neuralgia. Nothing fits all. There is no one size fits all, because the medical condition of the patient, the respiratory, the cardiac, if he can tolerate the anesthesia surgical procedure, has to be put into the equation before making the decision where to go. In general, the younger the patient, we go more into surgical microvascular decompression. The older the patient, the less fit patients, we try to go to percutaneous procedure. Microvascular is the choice, no question asked. However, if you have the right candidate in terms of low risk and high yield, recurrence of microvascular compression is not zero. We have to put this in mind, and we have, when we are counseling the patient, it's not we do it and that's it. Hopefully that's it, but when we go to statistics and when we go to literature review, 1/4 of the patient lose the benefit in 10 years' time. A reason for recurrence, we have, as described, go in a logarithm to rule out possibilities before you decide to go again to microvascular decompression procedure or to go to other options of treatment. And anesthesia dolorosa, it used to be a very dramatic pain syndrome. Nowadays it's less and less frequent because we start to be aware of it, and we start to try to avoid it by less radiofrequency, less radiosurgery, and more selective balloon compression. I hope by this I illustrated some highlights on the management of trigeminal neuralgia with some focus on the surgical technique. And thank you very much for your time and your attention. Thank you.
Thank you, dear Ahmed, for that really nice presentation, nice review for our colleagues around the world of the whole concept of microvascular decompression. That's very neat. I want to share with you and with the audience actually a little nuance to microvascular decompression that I introduced. See, the whole issue, as Dr. Ahmed showed, that you get one chance in MVD, and you want to really cure the patient if you can. And because I was doing a lot of surgeries, aneurysms and AVMs awake, I thought of the idea, if we can document release of pain during surgery, make sure there's no other loop like the case that Dr. Ahmed showed, that the previous surgeon failed to recognize the exact location of the compression. So I'm going to show you very briefly something here of what I introduced that hopefully will take away that risk. So if you watch this here,
origin of the fifth nerve, and
you see that's the fifth nerve there.
The loop of ICA.
I'm putting
and
a Teflon
very
piece.
Gently placing the Teflon, and then it is important to be able to document that we have space between the loop of the vessel, as here, and the root entry zone.
So this is
We're
what
going to see if we're going to be able to get that pain. Now go ahead and we're going to put a brush in your teeth. Is that starting any pain for you at all? No. Okay, let's try it one more time just to be sure. Is it starting any pain? No. No. Great. Thank you so much.
So what you see here, the main symptomatology, a lot of these patients brushing their teeth brings a pain right away. It's a classic thing. And in this specific patient I showed you, you couldn't even touch her face. You can't, just before surgery, we couldn't even touch the toothbrush to her teeth. She'll have pain right away. So what we did, fine. I did what I believe is a separation with the Teflon piece. And during surgery, we're touching her teeth. She's had first time in years, she's having no pain. That documents for me that before I leave surgery, we took care of the problem, because at her age, you only get one chance to operate, okay? So by advancing this technique where I know that I received cure during surgery, there's no other loop behind, nothing crazy before I leave the surgery. So this is another advance in really kind of getting to that maximal limit of microvascular decompression. Plus, for older patients, general anesthesia is more risky than the way I'm doing it. It's less risky. So that really changes the paradigm, where they say for some older patients, sicker patients, maybe do radiosurgery. But as Dr. Ahmed showed, radiosurgery is not so good really in the big picture. So with our technique, we're doing the best treatment for microvascular decompression, but with less risk because it's not under general anesthesia, and also documenting that we could cure it right away. And we've had some cases where I put the Teflon and the pain is still there. So I had to go around and release a lot more stuff. So it really allows me to know right away and to maximally do this. So that was a nice way of taking our aneurysm and AVM experience in Awake and doing it with MBD. And this has been published in the, in World Neurosurgery with our data. So that was kind of a nice little nuance to the world of MBD. What do you think, Dr. Ahmed? Your audio is off, Dr. Ahmed.
This is definitely very interesting. This is definitely really pioneering in this. I totally support the idea. The idea is very brilliant. I'm just worried about a couple of small things that we have to put in mind. Doing awake craniotomy in a 60-year-old, 70-year-old, we take it with a grain of salt, if you want to say it, because the patient is not supine. The patient is tilted, the head, as you showed, to one side. The chest may not be in the best condition. So we always worried about this. Sometimes when you dissect more around the trigeminal nerve, right from right to left to up and down, looking for all around, this by itself causing minor trauma to the nerve. And this is nothing but a balloon compression. So yes, the patient may improve, but sometimes you have an excellent experience with this, and you have your team in an excellent way with minimal amount of manipulation of the nerve, that you should not expect balloon compression-like effect before you call the patient improved. Because I do believe the patient who improves from venous decompression, it's not really venous decompression. It's just manipulating the nerve by putting the Teflon right and left and whatever. This is balloon compression. This is a traumatic injury to the nerve, and the patient will improve. Not usually happen like this, like you showed on the video, but it's a very brilliant idea. You have to have an excellent anesthesia with you, a good candid interview for cardiopulmonary function, that the patient is not in supine. But I believe this is definitely something to follow, especially in a young patient that we do microvascular decompression for, then definitely way to go.
Thank you, Dr. Ahmed. No, the points you made are very important. First of all, with my aneurysm, AVM, and MVD experience, I said in my lecture earlier in this week about awake surgery, this can only, and Dr. Ahmed is bringing this point up, this can only be done in very experienced hands. Those who do awake surgery all the time. This cannot be done, oh, today I'm going to do it. No, 100% no. This takes a lot, for people who do this all the time, like I'm doing this all the time, you have a system, you have an anesthesiologist, we have, finely tuned the system how to do the awake procedures. So I'm only showing it as a nuance. This really it can only be done in those hands who do this all the time. So this has been a beautiful presentation, Dr. Ahmed. You did a great job. You showed us a big picture view. It's great to have a speaker from your part of the world, from the Arabian Peninsula. It is great. We've had speakers from all over the world. So you're representing that region of the world, and you did a beautiful job doing it. And we thank you. We're essentially out of time here, but thank you for that review. And please give our regards to all of our neurosurgical colleagues in your part of the world.
Thank you very much. Thank you very much. And we hope to open this channel of communication with the rest of the world through your organization. And thank you as you aim to education, and this is something we should all work toward this aim and this target.
Thank you, Dr. Ahmed Alkhani. Thank you.
Thank you.
Thank you, Dr. Ahmed.
Natalia and Ahmed, please, if you want to say a couple comments.
Yeah, thank you, Dr. Ahmed. This is some kind of problem which requires a lot of techniques and procedures, because these patients are suffering from pain for years and they even can do suicide. So that's something that, you know, usually patients go to the doctor, they feel like not good, but after go from the doctor after the procedure, they feel better. But after this procedure, patient, I'm sure patients are taking you like a god, you know, because you save them from that kind of pain. That's impressive. Thank you very much.
Thank you, doctor, for sharing your knowledge. It's amazing how you do this neurosurgical techniques. And I'm going to speak in Spanish to all the audience. Pues agradecemos al doctor Ahmed Alkhani por su magnífica ponencia. Y les recordamos que la siguiente ponencia comenzará en breve. Para que sigan sintonizando, reiteramos un agradecimiento al señor embajador Jorge Herrera Ramos por ser el presidente de este congreso, y a todos los organizadores, al comité, al doctor Salim Abdurraouf, a Natalia Freudchenko por estar con nosotros. Dr. Ahmed Alkhani, again, thank you very much. It was a pleasure for us to hear you.
Thank you very much, everybody. It's great. Our regards to all of our audience around the world. Until next time, thank you very much.
Thank you. Bye-bye.
Bye-bye.